Welcome to Doc Talk, a weekly podcast featuring Monument Health physicians addressing medical topics. Tune into your health with Monument Health.
Well, hello again, everybody, and thank you for coming out to the Black Hills Stock Show and Rodeo, specifically for our second live Doc Talk. You didn't have to be here, Doctor, for the first, although the butterflies are gone now, so this is old hat, and we'll be ready to go, all right?
Absolutely.
This is Dr. Pial Hope, who is a surgeon at Monument Health, specifically a surgeon who works with robotics, which is something that we want to talk about today for sure. So my first question really for you, Doctor, would be when the robot overlords take over, how do you feel that our medical, that our health, that the system is it gonna be okay?
Well, they're watching me now, so I don't want to. No, it's so one thing to probably clarify just off the bat is that robotic-assisted surgery is still completely human surgery. It's a tool or an extension of the surgeon's hand. There's nothing that the robot does autonomously or on its own. It's really just a tool that I use to facilitate an operation. So if I move my hands a certain way, the robot does the same. And maybe some of you had a chance to see the demonstration or saw the robotic platform here at one of the booths for Monument Health. But I mean, the kids were loving it and they were dominating, which is giving me some anxiety about my future in this career. But in general, that's what it is. It's just a tool.
Well, what led you into this? How did it all start for you, Doctor, that led you up to the robot like the Da Vinci?
Sure, yeah. So, I always, when I got into medical school, I knew I wanted to be a surgeon. I just like procedure-based specialties, and I liked the ability to do something for a patient and have them be better immediately after doing a thing. So maybe that speaks to my impatience in general. But I did my general surgery residency training where we were fortunate in Michigan to in Detroit area to have access to the robotic platform. And so my training really began with robotic surgery in addition to traditional approaches like open surgery or straight stick laparoscopic surgery.
So you were doing this right away. I mean, this wasn't something that came down the line.
That's right. Yeah. So I was kind of, at my infancy of training, it started on the robotic platform.
Excellent. Was there a learning curve for it then, or since you got right into it, was it relatively easy to pick up?
Right. I mean, the name of the company with that's kind of the front runner in robotics is Intuitive Surgical, and I think it's aptly named for a reason. It is quite intuitive, and again, as demonstrated by the 5 and 6 year olds that have been doing so well on the platform, that it is just, you get on it, and it just makes sense. So there is a learning curve for maybe if you're really entrenched in traditional approaches, or you haven't. I would just say for the next generation, especially especially young kids that play video games, there's research that shows they do even better on these platforms. So this
is the one time, kids, when you'll be able to look at your parents and say, "Look, I got to do this.
Yeah.
I'm gonna be a doctor.
Yeah,
this is exactly how this is going to go.
I'll write you a letter or a prescription for video game playing twice a day at least."
What types of surgeries then do you specifically perform with this, doctor?
Sure. Yeah. So I try to do any intra-abdominal or surgery in the abdomen that I do. These are surgeries that either take a organ out that might not be functioning well, for example, the gallbladder or the spleen, or if you have a trouble with your adrenal gland, a small gland above your kidney, I would do robotically. Additionally, I do heartburn surgery for people that have terrible heartburn due to, for example, their stomach slipping up into their chest. Just doing it robotically has really facilitated that operation.
Wait, that's something that can happen? Your stomach can slip up into your chest?
Anything can happen if you can think it, and I've seen it. So, but this is quite a common problem. So, and it leads to pretty debilitating heartburn. And for people who, for a long time, they can take medicines to help that, but sometimes at some point they either want to stop taking the medicine or the medicine stops working, and you find out it's because they have this type of hernia. So that's another operation. So anything that I can do that I would have done laparoscopically, which means without the robot, just still minimally invasive with tiny incisions, instruments, and cameras, but I would do robotically now just because of the great dexterity and the visualization you can get.
Now, if you've seen the robot in the concourse there in the ice arena, it's called the Da Vinci. Do you know why it's called that? Do you know why they gave it the name?
Probably because Da Vinci was an artistic genius, and it's like art and science. I'm not sure if that's a good question. I'm sure there's some lore behind that, but it just sounds.
Well, I think your answer is perfect. Exactly. Right. I mean, he was an inventor, an artist, and I suppose that's just a great name to give to it.
Yeah, it seems natural.
Now, if you have seen it, there are 4 arms on it, correct?
Right.
That you operate. And before we came down here for the podcast, I was asking you some questions about the arm and why there are only 4. And one story that you told me is that the 4th arm can actually be used to hold up organs that need to be taken out of the body and held up.
Right.
And that's what it can do instead of another person doing that.
Right. If in order to work in a certain area, if you need access to a part of the body where you're doing surgery, there are often things in the way that you don't want to do surgery on or do anything to. You just need it to move to the side. Whereas previously you would have to engage an assistant to literally grab it and just hold it aside. Now you can just use that 4th arm to grab it, move it to the side, and just freeze it in space. And it really facilitates exposure, but also frees up another expert or assistant to do other things that are more helpful.
So are there less surgeons and specialists in the room now because of the robot too? Or is it kind of the same amount?
So usually surgeries are done primarily with one surgeon unless it's an extraordinarily complex case or a type of case that does really require 2 surgeons, co-surgeons. But you do, depending on the operation, you almost always have some sort of assistant. That's not a surgeon, but a specialist in surgical assisting. They go to school for that and they train for that. And they don't do major parts of the case, but they help facilitate the case for the surgeon. And now what that allows us to do is we can do these operations. Now I have more control. I can do the whole operation myself. I can do it day or night, 2 in the morning, 3 in the morning. It doesn't matter if Bob's not here to hold the organ aside. I can do it. So don't have to worry about any of that. So it's really amazing in that regard.
So in special situations, it's actually something you can do alone if it absolutely had to be done that way.
If I absolutely had to do it, yes. You still would want someone at the bedside. It doesn't have to be a first assistant. It could be a surgical scrub technician. And a technician has a role of passing instruments to the surgeon so as to make the case move on efficiently. But the assistant can change the instruments for you at the bedside. But if something were to happen, if something got disconnected, you do need someone at the bedside to help with that.
Okay. Can you walk us through a little bit about how it works in an actual procedure? Let's talk about your stomach going up into your chest.
Sure.
So how does that robot? In kind of layman's terms, then how does that work when you're in there and the procedure's starting? What's happening?
Sure. Yeah. I just want to make one comment. I think it's quite apt that we're the venue and the setting because one of my the most common type of patient that has this problem that in my practice are ranchers that got bucked by either a horse or sometimes a cow or just a trauma like that, even car accidents. So any kind of dramatic force like that can sometimes cause that issue. Mm-hmm. So to answer your question, you have the patient come into the room just like any other surgery. Pretty much everything's the same up to the very last moment, and that is the anesthesiologist or the anesthesia provider will put the patient to sleep so they're comfortable and having sweet dreams, and we will clean the belly where we're going to do the surgery using a special cleaning solution. After that, we do a special timeout to make sure we're all on the same page, that we have the right patient, we're doing the right procedure on the right side of the patient. In this case, I'm lucky, it's just belly, so there's no side, it's just the belly. And after that, we have to dock the robot arms into the patient's belly. So there has to be a way for the arms of the robot to be in the abdomen so that when I am moving my hands and doing the surgery, that I'm actually doing the surgery in the belly. That requires me to place these little ports. They're like these plastic or psilastic tubular structures that you make a small incision, you put the port in, and you have to hook it up to a carbon dioxide gas insufflator. And the reason you need gas is because right now, all of us, when we're sitting, we have our belly pretty much, for lack of a better term, smushed up against your organs on the inside. There's no space there otherwise. In order to do surgery, you need to make some space. So you put a port and you basically blow it up like a balloon, and it goes up out to here, and you have all this working room. Now you can do the surgery. And after you put several ports in, you can connect the ports that are going into the belly to the robotic arms, and then you can do the surgery by putting the instruments through the ports.
And with the gas that you're injecting too, that's also part of the Da Vinci machine in most instances, isn't it?
In the most, this is the newest edition. The newest edition of the Da Vinci machine, Da Vinci platform, the DV5, does have the gas insufflator all integrated into that tower that you've seen. Whereas before, you had to use a separate machine or a separate device or a vendor in order just to provide the insufflation. Okay. So if you, and we have the older system still, and it works just fine. It's just more clutter, and it's not as sleek. It's like the iPhone 15 instead of the 16. Are we on the 16 yet? I don't really know. Could be the 17.
Yeah, you're right. It's the 16.
Okay.
Yeah, that's the most recent. Yep.
Right. Yeah.
So once everything is ready to go, then what is your next step with those arms?
Right. So we placed we're all docked. I now at this point will break scrub, meaning I'm otherwise sterile, gowned and gloved. I take that gown off. I walk in the same room to the side where that console is, where there's that little console where you sit, and you bring it closer to you, and you do the operation. You go through the steps. Now,
are you in the same room then too, where the patient is?
Yes.
Okay.
Yeah. For now, hopefully we can operate at home in my pajamas one day. But for now, we're still having to come to work. And I love that. I think connections is still important. But I don't imagine you want me to walk you through the steps of a hiatal hernia repair.
I don't.
Okay.
Not personally. No, I don't want you to do that at all. Honestly,
it's riveting. I don't know if anyone's interested. We can talk offline.
We'll have an addendum to this podcast where you can just run that down.
See addendum.
So obviously there are huge advantages to this. In your practice, what have you seen as some of the biggest advantages to having this type of surgery or this type of equipment at your disposal?
Sure. Yeah. There are operations that you can do now in a minimally invasive fashion. So when I say minimally invasive, there's two modalities of surgery. There's traditional open surgery. That's what maybe people think of when they think of surgery, where you have a cut on your belly to make a big open incision and look at things and do surgery that way. And that's how it had been done since the very beginnings of surgery. And there's also minimally invasive, which could mean a lot of things, but typically small incisions, instruments and telescopes, cameras, etc., to go in there and do the operation that way. So before, if a patient had multiple operations in the past, and they have a lot of scar tissue in the belly, or they have some anatomical consideration that makes the operation very difficult to do with the traditional laparoscopic methods, meaning two sticks that you use to go in through these ports, as opposed to this robotic surgical platform, then you could not do it. You just have to resort back to open surgery. You would have to do a big open incision. They'd be in the hospital for however long, much longer than it would have been if you had done it laparoscopically, and they would have more discomfort. There would be potentially more complications down the line, such as hernias. Anytime you violate the natural barrier to the patient's abdomen, you can have weakened tissues and you can get a hernia or a bulge there. But now, I can pretty much. There's very few cases that I do not see myself being able to do minimally invasively. So that's a huge positive for patients because I can discharge them outpatient now. Operations that you would do, and a patient would be in the hospital for 3 days, now go home from recovery after 4 hours of having surgery. They're up and walking sooner. They're back to. Some people say, "Do I really have to take a week off?" And I say, "Yes. You should probably take a week off." But
at least you could be at home at that point. Still, I mean,
right.
You're out of the hospital,
Certainly.
right?
So you can do you can do more complex cases. Mm-hmm. You have much better visualization. We're seeing structures we'd never seen before because the resolution is so much better. It's like 4K, 8K, whatever. And you have stability of the camera. There's no human assistant holding a camera for like 4 hours, getting tired, and potentially starting to wobble and making it more difficult. It's perfectly stable the whole time. The dexterity, the human hand has so many degrees of freedom. You could do so much. But it really, and you can't translate all your degrees of freedom when you're just using the straight stick laparoscopic surgery. When you're using two laparoscopic instruments, you don't have the same degrees of freedom. But with the Da Vinci surgical platform, you pretty much, it's an extension of your hand. So everything I could do to suture or stitch or sew, I can now do very easily just doing that. So those are all some reasons or benefits to the robotic platform.
Well, then on the opposite side of that, I know, how long has robotic surgery been around in this sense?
Sure, yeah. I mean, there were prototypes, but 2000 probably when the first system started coming out, and the Da Vinci Xi platform, which is just one iteration before the most recent one, which is the DV5, was out since April of 2024. So it's been, April 2014. So it's been out for more than a decade.
But it's still new technology. I mean, this is still very, very new.
Yes, especially the newest iteration, and they're innovating all the time. So one thing, for example, that we didn't have until most recently was that when you're using the robotic platform to do the surgery, you don't really feel how much tension there is. When you grab something, you lift it up, you don't know how heavy it is because you're not feeling it. It's just a robot, doing it when you're moving your hand. You can look at the tissue, you can see if it's okay, that looks like it's on quite a bit of stretch, that looks like it's pretty tight, but you can't feel it. Whereas now, the Da Vinci 5 model, the newest one, actually lets you feel when you lift. So, but yes, it's new tech, and it's always, new things are always coming out, innovations are happening all the time, and we haven't even begun to implement artificial intelligence to this platform to help facilitate operations.
That was going to be one of my next questions here in a little bit too, is if that is going to, I'm assuming it's going to be incorporated into this eventually. I think what people don't understand a lot too, really quick, kind of to the side here about artificial intelligence, is that I had one of the doctors we talked to on the podcast here say that artificial intelligence has been used in medicine since the 70s. It goes back to your ECG machines. So it has been in use for 50 years already. We just didn't call it that, but in essence, that's what it is. And I think that's kind of reassuring when people know that, this isn't something that's just happened in the last 5 years. Doctors have been using this for a long time.
Yeah, absolutely. The sophistication has definitely exponentiated. It's gone through the roof in what you can do. But yeah, rudimentary forms of artificial intelligence has always been in the medical field, and it helps with a lot of things, like when you get labs drawn, for example, automatic counts. When you have your heart checked with like you said, ECG or EKG, those types of things always happen. There's some basic computing power that needs to go into interpreting those things and helping facilitate. So you're not stuck all day, taking much longer to interpret. Now you always need, for example, EKGs are a very good example because sometimes you get a readout from the machine and all of the EKGs need to be overread by a specialist like a heart doctor so as to make sure that what's being told or what's being spit out by the machine is not completely out of this world. It makes sense.
Yeah.
The patient's clearly alive. It's saying there's no heartbeat. I'm not sure that really, but yes. But now the sophistication is really it's really something else.
So what are some of the limitations that you encounter with robots then right now? Something like the Da Vinci.
Sure.
What are you, if ideally if you could add something to it?
Right.
What do you want?
Well, current limitations are, first is access for patients because of cost. Sometimes hospital systems may not be able to afford a robotic platform, and that does decrease access to care for patients, and that's unfortunate. And I think that's being improved every day, especially with better pricing and different kind of creative financing strategies. Additionally, with the DV5, I wish the next one thing it could do is maybe do my laundry. That would be phenomenal. It really doesn't do that yet. But maybe better, they've already done the things that I wish it had. Now they have a charger for your cell phone right next. It's like a wireless charger, so that's pretty amazing.
Do they really?
They really do. They certainly do. Yeah.
That's great.
Yep, that's the selling point there. Yeah.
Well, one question that a lot of people, it's exciting. If you enjoy technology at all, ever since we were little kids, this is when we've dreamed of someday robots are going to be doing these things for us, right? And it makes some people excited. It makes some people extremely nervous to have these kind of machines that are working on you. How do you reassure people that, look, this is safe, you're going to get better faster, and it's a vast improvement over what we used to have?
Sure. Yeah. I just emphasize during my preoperative counseling session with the patient when I see them and I discuss, here's the problem. Here I think are your options or potential solutions to the problem. And part of informed consent with the patient is to talk about risks, benefits, as well as alternatives. So when I talk alternatives, I can say, you can do this laparoscopically, you can do this open, which I don't even offer that really, unless I really had to, or you could do it robotic assisted. It doesn't make much of a difference in terms of cost for the patient. None of that is really trickles down for the patient. It's just how things are charged to the hospital, et cetera. So there's less reimbursement. I mean, the hospital's spending more money on some of these instruments, but the cost is the same to the patient. But I reassure them that the robot is not doing anything autonomously, nor do I ever really envision it doing anything autonomously, just because you need that oversight. We've had AI in basic cardiology for EKGs for, as you said, since the 70s. But still, it says some crazy things. So you still need like a human, someone who can look at things and make sure what's being done is actually makes sense. And so I can't predict the future. Who knows? I bet if you told, someone from the 1800s that we'd be doing what we're doing today, they would just probably, burn you at the stake or something. I'm not sure. That they'd probably think you're a witch. But, just in the last 50 years, I mean, just in our lifetime, some very, very big leaps have happened. But I still think the human aspect to just make sure that everything's being done appropriately, that a disaster doesn't happen. It's never going away.
Right.
And I think the connection with the patient is important because the robot can't develop a relationship or a doctor-patient relationship with the patient. The robot can't. It can spit out all the risks, benefits, and probably no one would ever get surgery because you can, there's a 0.000% chance that you'll have this horrible thing happen, and it'll be all listed there. And they won't understand. I think relationships are important.
Yeah.
And the post-op follow-up is important. So I think as a facilitator, as a tool, absolutely important. But I don't think, I tell people that it's just an extension of the surgeon.
That was going to be one of my next questions. If you ever feel, and you kind of touched on it a little bit, that we'll ever reach a point with any type of procedure that oversight doesn't need to be there. I can't think off the top of my head what that could be. You think about the stuff that is always, anything can have a complication. Any procedure you go into can have a complication. But we have perfected things like tonsillectomies and removing appendixes and these very simple procedures that you can go in and have done. Do you think it'll ever where you can just roll in a robot, hit start, and walk off and do your laundry at that point, I guess? I don't know.
Yeah, I would hope the laundry gets done first. But, I can't, it's impossible to say because technology, the way innovation happens, it's pretty dramatic sometimes. Mm-hmm. I will just say, first of all, I'd like to know if you could teach me how to do a simple appendectomy, that'd be fantastic. Every appendix I've seen,
that a little bit. You're right.
What seems seemingly one thing to understand is for what for me might be a minor procedure, all right, something routine. I do this every day. Mm-hmm. My outcomes could be phenomenal. I've never had a problem. Whatever. For the patient, it's a major thing. It doesn't matter how minor it is for them because anything can happen. And one thing I think that really will be a barrier to self-operating or autonomously operating robots is that no two people are the same. Anatomy, there's no real standard anatomy. We have textbooks with anatomy, but they're just idealized and they're almost never really, 50% of the time that's what you expect, but other times it's just aberrant, it's just different. So for a system to know, to see that, to process that, and to change course, maybe sometime in the future, but right, appendectomies could be simple or could be one of the most complicated operations you've had to do. So that's the thing about medicine is you have to be humble and you have to know that disaster can happen at any time. You have to be focused. And I don't know that a robot can just do that anytime soon. Maybe, who knows, in 200 years.
Well, and that human connection that you talked about, we've mentioned it here before on the podcast, is becoming more and more important in your practice. It used to be a lot of these doctors would go in, put out their cigarette, and then, say, here's the medication you're going to need. Here's what you're going to do. Not that they weren't great doctors, but
Sure.
they saw a lot of people, and that was the process.
Sure.
But now, especially in working with some of you doctors from Monument Health, one of the big topics of discussion that always comes up is the time now that you spend with people to first get to know them a little bit, and then to help explain what's going to be happening in the procedures, And I think that there has to be a percentage that you can point to say, this is making a difference. This is really, really just the time we spend talking to people. Do you feel that way?
Absolutely. If you're going to allow, first of all, I find it incredibly an honor and a privilege to be able to operate on someone, to have someone trust me with their life, to basically have them knocked out and have me do something so invasive. So I find that to be an extraordinary privilege. But I feel you need to have a level of trust, and it's not like McDonald's where they have the screen, you can just order whatever and you can just get your appendix taken out.
That's what's next.
Right. Yeah, it's coming. Yeah. But right, and I think relationships are very important for that reason. You have to put someone at ease. You have to be able to answer their questions. There's cultural considerations. Sometimes if you read a transcript from a courtroom, you may not get the true gist of what is going on. This is a completely separate analogy, by the way. That was a big jump. But if you just read something, you might not understand like the ethos or what is being said. How are things being taken? How are people really feeling? Unless you're there. And so the robotic platform can easily, use ChatGPT or probably Google AI or whatever to give you a list. Again, a pamphlet. You could read this pamphlet. Has all the information, probably more information than any human being can ever regurgitate during one single setting. But to really understand it, to intuit a patient's values, to make them feel okay and be their guide through this process, I don't think the robot can do that. And I think that is probably the biggest thing, is the human aspect of it is important. Despite the technical aspect, maybe, who knows, intuitive surgical is kind of ridiculous. They can probably get it done soon, but I think the human aspect is invaluable for that reason.
Are you excited for the future of this when it comes to kids now that are big into technology? And everybody will make the video game joke when it comes to procedures like that. But do you see that? Do you see that as a benefit for these kids if they're excited about it, and if they can get into the school and the knowledge and everything? And I mean, does that excite you to see what's coming up?
Yeah, it's extraordinary. I have a 2.5-year-old daughter who I brought to work with me yesterday. We had a demonstration day before yesterday. We brought the system to the hospital and had an open house for the public as well as for some of the other surgeons, because this is the newest platform. And I put her on the system, and she was, she's 2.5, so she wasn't like doing high scores like today, but she was moving the instruments, and she was excited about it. And I think if we can curry excitement among the next generation, that people will still be very interested in pursuing a discipline like surgery, which can be pretty a long road, and it can be stressful. But if you're passionate and you really are interested in what you're doing, I think that really makes it easy. It doesn't feel like work as much.
Right. Now, is the Da Vinci the only robot you use? Is it the only robot you work on? Because I know Monument has, they have Rosa, which is another one that I'm familiar with, and the Da Vinci. Is that the only one you use, though?
That's the only one I use. However, there's robotic platforms in different disciplines of surgery. There's to just break it up, there's soft tissue surgery. So what I do is soft tissue, meaning organs and things inside the abdomen. There's also orthopedic surgery, where like bone surgery, and the Rosa is for that. And so there's different disciplines I can do it, and there's also different types of soft tissue surgical platforms. For example, the one you saw outside is a multi-port, so it has four arms. But the Intuitive Surgical also has a single port version, which looks like a snake basically, and the arms or instruments come out from that, so you can just make one incision, which the Federal Drug Administration has not expanded the indications to allow general surgeons to do general surgery with them yet. Hopefully soon, so I can do that. That's so cool. But you can do colorectal procedures with that, and it's really taken off in urology, because you can do surgery without actually going all the way into the belly. You can think of a sandwich. You have different layers. You can sneak in deep to a layer, right, just above the lettuce but beneath the bread, and just kind of do the whole surgery in that layer without doing anything traumatic to the belly on the inside, which, A, decreases trauma to the abdomen, so you have even less pain and recovery times are quicker. And B, what if you have a patient that's had 7 surgeries already in the belly? So the scar tissue is going to be so dense that you couldn't do laparoscopic surgery. You would have to do open surgery. In this way, you can avoid all that mess altogether, stay between those layers, and do an operation. And not every operation can be done this way, but you can do an operation that otherwise would not be able to be done. So it's pretty amazing what's out there, and I'm excited for what's coming. But yeah, there's multiple platforms.
Well, and it's really nice to know that we have this right here in Rapid City.
Oh yeah.
You don't have to go to Denver or Minneapolis or Rochester. You get to it's right here.
Yeah, Rapid City, we have multiple robotic platforms, but we're also very special in that the single port version. I mean, we're one of the few facilities in the nation. I mean, we were one of the earliest ones in the nation to get it, one of the highest volumes in the nation to really run with it.
Mm-hmm.
So we might be Rapid City might not be the biggest city in America, but it is certainly at the forefront of this technology.
Now, my last question for you, Doctor: do you give them names, right? You
yes,
give them.
we do.
What do you call the one that's in your room, your surgery room right now?
Yeah, so the single port is Ollie, and we have there's Natasha, and gosh, I'm forgetting. I can't believe
the one you're forgetting.
The one I don't use. I don't pay much attention to the other one. Yeah.
On Monday, it's going to be like, I didn't even get a mention.
Well, I don't want Natasha to get really upset, or we have a working relationship. There's some appearances we have to maintain.
Right. Dr. Pial Hope, thank you for coming in and doing this.
My pleasure.
I really appreciate it. And you're one of those doctors that we're so glad that we have, that we hope we don't have to use.
Sure.
But I'm glad that you're there, and the equipment's there, and your dedication comes through, and we really appreciate it.
Of course.
So thanks for coming out and talking with me, Doctor. I appreciate it.
Thank you. Thank you all for being here. Really appreciate it.
All right, thank you. All right, do you guys have any questions at all for Dr. Hope? Anything at all that you'd like to ask him before he has to jet? Yes, go ahead.
I know you're a general surgeon. What are all the specialties you can utilize Da Vinci for?
Sure. Yeah, that's a good question. So Da Vinci multi-port systems such as the one here today, as well as any previous iteration of that version, as well it can be used by any belly surgeon, belly and pelvis. So OBGYN, right, for the female reproductive organs, as well as cancer operations of any intra-abdominal space, anything in the belly. Urology, that's kidney, bladder, ureters, prostate, etc. General surgery, and we do, if it's in the belly, we can do it for the most part, with the exception of very specialized things that I just mentioned earlier. You can also use the robotic platform for the chest. So chest surgeons can use it. Thoracic surgeons, for example, if you have issues with your lung, you can do Da Vinci surgery with that. Colorectal, which is a subset or a subspecialization under people who do general surgery, they go on to do an additional year, and that's focusing on colon and rectum problems. Pretty much many surgical disciplines have now adopted this as their primary operative modality.
Excellent.
It's a good question.
You had one too?
Yeah.
Also, children can do it. I forgot to mention children. Yeah.
Okay, so you had mentioned that certain patient situations can prevent you from using the Da Vinci system. Is there any specific procedures that you would say, no, I'd rather just do this myself?
Do this myself. So I want to characterize. I'm always doing it myself.
Yes, without it.
Without the robot.
Without the robot,
Yeah.
yeah. So it's less a procedure-specific determination and more a patient characteristic determination. So if someone is extraordinarily, has low weight, has a body type where their torso is very small, that could create some problems with the multi-port system because you can't put enough space between the trocars. They'll just kind of bump into each other and clash. That's one consideration. Other ones are extremely sick patients that are so sick that they cannot tolerate putting the gas to make their belly, to make that space, and that would invalidate not just the robot because you can't use the gas, but also just traditional laparoscopic surgery. So those types of patients. Patients who've had a lot of surgeries in the past that might have a lot of scar tissue because of the way you enter the belly laparoscopically and because of the type of visualization you have, they may not be the best. And even then, and I take on complex revisions. I have a lot of my partners a couple of my partners send me certain patients that they know I can probably do on the robot versus otherwise. So it'd be rare, but still there are certain considerations where if they've had a lot of surgery and you worry about making an injury just by putting the trocars or cannulas in, then you would consider doing those patients open.
All right.
That's a
Any
great
other
question.
questions? Yeah.
Yes.
Natasha and Boris.
Boris.
Boris is the name of the other one. Yeah. Yeah.
Gosh.
Of course.
Yeah.
Yeah.
Well, no one likes Boris anyway, so Boris stalls.
He had a question here too.
You were talking about how surgeries differ from people who have multiple surgeries and scar tissue, right?
Yes.
Well, when I had to go through my extensive back surgery, they went through 2.5 hours through my stomach, and I told them beforehand that I had a mesh underneath my belly button. Would your machine be able to do that process of putting a steel spacer in somebody's spine by going through their stomach with that in mind, with the mesh and plus multiple scar tissues in that lower part of my stomach?
That's a very good question, actually, and it requires a little bit of explanation. So what sounds like you had was something called an A-lift procedure, where they fix your back problem, but they fix it by moving all your organs to the side and scooching in and coming in through the front, just to fix the back problem. So it's spine surgery that can be done by an orthopedic surgeon or a neurosurgeon that does spine surgery, but requires also the assistance of a general surgeon in order to do that. Those procedures typically are not being done robotically from the general surgeon side of things because the spine surgeon needs exposure. They need that open space. So that's primarily the reason. Now we could get with the single port system I was talking about with just the one port. Urologists are doing surgeries like that. Not for the sake of doing spine surgery, but they're staying outside the abdomen. That's exactly how they do it. But that wouldn't give enough space for the spine surgeon to come in and then put the spacers or do what they need to do. So we have to compromise, and because the spine surgeon needs more exposure, we'll do it open. Now the second part of that question, that was an interesting question about the mesh being there. And sometimes you try to avoid mesh that's already there, and other times you can't because you just have to bore through the mesh and violate the mesh, and that's even more of a reason to consider minimally invasive surgery, because when you have to bore through or cut through mesh, you rather have a tiny 5 millimeter or half a centimeter hole through that mesh and still preserve its integrity or the structural integrity than, for example, just doing a big cut and just completely opening the mesh up, which violates its integrity and doesn't the mesh really it never grows back and attaches to the other side of the mesh. It's not like organic tissue where your body can heal by growing into each other, but if it's inorganic tissue or mesh, they're cut edges now, so you have to use permanent sutures to bring them back together. But that's a great question. So if you do have mesh, that's another even better reason often to do it minimally invasively.
Yeah, thanks for the question. Appreciate it. Anybody else have a question? No one else? Well, thank you all very much for coming and listening. We really appreciate it. Dr. Hope, thank you for coming down and doing it too. Yeah. We'll just have, 4 more of these. You want to this week? It's fine. We can.
I was thinking tonight.
Okay, absolutely. You bet.
Let's go.
Let's go up to the Cowboy Bar and we'll do some more.
Yeah, I can go all day.
All right. Yeah. Thank you guys for coming out. We appreciate it.
Thank you so much.